Please go ahead, sir. We are live now.
Good afternoon and welcome to another edition of webinars in the series Illness to Wellness. Uh, in the past few programs, we have been focusing on non-communicable diseases, and today this program is specially dedicated to uh, the non-communicable diseases as a new health challenges for Northeast and Assam. So this program is dedicated to Assam and the other Northeast states. So thank you so much to all of you for joining in on this. I would say from Delhi, a very rainy and to some extent a pleasant afternoon. Welcome all of you. Welcome our guests, our panelists. Uh, I would say we are very thankful to them for joining us at this time, and we are honored to have you on board us, all of you here. You would be enlightening our audience on the challenges being faced uh, by all of us about the non-communicable diseases which have become the major killer in our country and all over the world now. So thank you once again. I would like to give start with small introduction of our panelists. We have with us Dr. Bikash Rai Das. He's an MBBS, MS, DNB, MNA, MS, MBA. He's a senior cardiovascular and thoracic surgeon. He's director and senior CTVA surgeon at Ayushundar Super Specialty Hospital. He's also secretary Heart Care Society of Assam, Guwahati chapter. Dr. Bikash is a young, dynamic, highly trained and skillful cardiac surgeon from Northeast India and presently works as a senior consultant cardiothoracic and vascular surgeon in Health City Hospital, Guwahati, a premier tertiary level super specialty healthcare destination. He is an alumnus of Rabindranath Tagore International Institute of Cardiac Sciences, Kolkata, the largest and busiest heart care center of Eastern India. He is the first surgeon from Northeast India to clear the super specialty BNB examination in cardiac surgery. He has a number of accolades and he has worked far and wide. It's a very long description. And we all know about him. And he is the first physician to start stem cell therapy uh, in Northeast. This is also one of the first. And he's associated with clinical research activities and presently undertaking many national and international clinical trials as a clinical investigator. He's a certificate holder of Duke University London and Quintiles International USA NIDA Clinical Trials Network, USA for Good Clinical Practices. He has a number of certificates and oaths to his honor. Sir, we would like to once again welcome you and thank you for sparing your precious time and being with us. Welcome once again, Dr. Bikash Rai Das. I'd like to also welcome Dr. Gayatri Pegu. She is MBBS, MD, and PM Nephrology. And she is currently the Assistant Professor, Department of Nephrology, Guwahati Medical College and Hospital, Guwahati, Assam. She is life member, Indian Society of Organ Transplantation, member, American Society of Nephrology, and member, Guwahati Nephrology Forum. She is actively participating in the fight against COVID-19. She has contributed in development of SOPs for management of renal problems in COVID, participated in webinars related to COVID-19, and actively treated many COVID patients. And she has been regularly participating in awareness programs, scientific programs, as a speaker, as a chairperson, and she has numerous publications in journals of national and international repute. So once again, we are honored to have you with us, Dr. Gayatri Pegu. Welcome and thank you so much for being with us. We also have with us Dr. Manas P. Barua. He is the promoter director and head of Department of Endocrinology, Excel Care Hospitals, Guwahati. Formerly, he's been the editor-in-chief of GMNN and former associate editor of these prestigious journals. He is a reviewer of various journals and member research committee RSSBI from 2017 to 19 and ESI from 2021 till yet. And He's been awarded the Award of Great Minds of 21st Century by ABI, the American Biographical Society, and IGM Best Original Paper Awards of 2011, Economic Times Aspiring Endocrinologist Award 2021. He has 152 articles published in peer-reviewed journals, original 37 plus 17 book chapters and 37 international abstracts, 25 consensus, clinical guidelines, and thousands of citations. And he's been a member of many very important, I would like to say, clinical trials which have to a certain extent changed the opinion and the therapies all over the world, not only India. So, sir, we are really honored to have you on board with us. Welcome once again, Dr. Manas P. Barma. And we also have with us Dr. Mukut Roy. He is a consultant endocrinologist and in charge of Endocrine Clinic, Tripura Medical College, Agartala, Tripura. He is a fellow of IACM and API, and he's a fellow of Royal College of Physicians, Edinburgh. He's joint secretary, Northeastern Diabetes Society, and central committee member. And he has multiple national and international publications to his credit. So welcome once again, Dr. Mukut Roy, and welcome to everyone. We also have with us Mr. Kaushik Datta. He's an eminent research person, and he is going to present a very interesting report on non-communicable diseases. He's the president of Thought Arbitrage India, which has prepared the report, which we are going to discuss today. So thank you for being with us, and welcome, Mr. Kaushik Datta. Now I'd like to set the ball rolling, and I'd like to start the session without coming between you and the audience. The audience is very keen to know about the non-communicable disease, as we understand that these are the diseases which have taken over as the major cause of mortality, the reasons of the death, over from the infectious disease, which earlier used to be the major cause of mortality or death. And the very worrisome thing is that people in younger ages are losing their life to these diseases. They have an immense cost burden. They cause a lot of economic hardships, not only to the country, but also personally to families and to the members of the society. A lot of productivity is lost because of these diseases. People who have had a lot of training, skills, they lose their life early, or they become incapable of performing their activities, their professional activities. So it has an economic burden also, except obviously for the treatment and other costs involved with these diseases. But the most important thing about these diseases is that they are actually preventable. That these majority of deaths can be prevented. So I would like to request all of you, our esteemed panelists, to give your opinions on behalf of, on your specialties. What are the non-communicable diseases and what they mean to you? So I would like to start with Dr. Gayatri, because she is a nephrologist, and she would tell us about the kidney diseases, which diseases and how. What is your take on non-communicable diseases, Dr. Gayatri?
Hello everybody.
Yes.
Thank you, Dr. Yeah, thank you, Dr. Keshe, for inviting me to this program. I'm really happy to be here. Before going in, let's come directly to the point, because we have got only 1 hour to discuss, and it's such a huge topic. So coming to my subject, kidneys. So till 10 years back, people probably were not so much concerned about the kidney diseases, or they were not aware of the kidney diseases. But over these years, we have seen that the number of kidney diseases is increased like anything. And it has been seen by data that around 850 million people worldwide suffer from kidney diseases. Now, if you ask me what is the major cause of kidney disease, it's because of diabetes and hypertension. So majority of the causes of kidney diseases are because of diabetes. More than 40% is because of combined causes of because of diabetes and hypertension, which are non-communicable diseases. Apart from that, we have also got some glomerular diseases, the cause of which, truly speaking, we are still not aware of. Some of which are very common in our setup, especially in the Northeast. So it may be related with the genetics, it may be related with the environmental factors. These things we have to find out. So what I feel is that, like, initially when people were more concerned about diabetes and hypertension to control them, but now they are more concerned about diabetes and hypertension because they know that this affects the target organs like heart and the kidneys. So they are more concerned that we have to control them because we have to see that the kidneys doesn't get affected. So prevention of this non-communicable diseases is must if we have to reduce the burden of kidney disease, because in the initial stage, the treatment of the cost of the kidney disease is very less. But once a patient develops full-fledged kidney disease, the cost-wise, it's an economic burden, not only burden of the health-wise, but it's also an economic burden.
Okay. Thank you. Thank you so much, Dr. Gayatri. That was really very important, that it is any kidney disease, and especially in the later stages, is a big economic burden, not only for the patient, but for the society and for the whole country. I'd like to come to you, Dr. Bikash Das. So what is your take on non-communicable disease? How would you explain
Yeah,
to our audience?
yeah. Thank you again for inviting me for this program, and I'm really privileged. And the question that you have asked regarding the non-communicable diseases. So if you look at the non-communicable diseases prevalent in our area, in northeastern India and in Assam, then diabetes, heart diseases, cancer, and if I have to name the four topmost non-communicable diseases, then there will be heart diseases, cancer, chronic pulmonary diseases, and diabetes. So these four will be my top picks. Now, if you look at the cause of death in northeastern India or in Assam, then obviously, just like all over the world, the number one cause of death is cardiovascular diseases. So there is no difference here also in northeastern India or in Assam. Now, if you ask me what are the causes, like in worldwide, if you look at the causes of non-communicable diseases, especially cardiovascular diseases, similarly in northeastern India also, we have causes like, say, increased tobacco use, prevalent in the villagers and all, then increased alcohol use, then say lack of physical exercises, and unhealthy diet also contributes a lot towards the causation of these non-communicable diseases, mostly the cardiovascular diseases. Now, if you look at the situation, then why is it happening? Why almost 80% of our people, they die of cardiovascular diseases? So I will pinpoint as lack of awareness as the first cause, because most of the people, they do not know the ill effects of tobacco use, they do not know how to control the diabetes, they do not know how lack of physical exercises can cause a cardiovascular disease. So that is number one, lack of awareness. I have 5 A's. So number one is lack awareness, that is lack of awareness, rather. Number two is lack of access. So we do not have good hospitals or good infrastructures. So if you look at an data from Assam, then there is like, if you take a radius of 5 kilometers, and whether there is a health institution or not within that 5 kilometer diameter, then in Assam, only 37% people, they have an access to a IPD. Only 37% of people will have an access to an IPD within 5 kilometer radius, and 68% people will have an access to the OPD. So still access or lack of access is the number second cause. Then absence of human resources. So that is a worldwide phenomenon, more so in India. Similarly, in Assam, also in northeastern area, also lack of skilled manpower is a big problem. And if you look at our terrain, we have riverine areas, we have hilly areas, we have international borders. So these are very different terrain, and the lack of access by roads and all these things are very much prevalent. Number 4A is affordability. So our patients are basically very poor patients from villages. So they do not have any access to other means of getting treated other than the government hospitals. So this affordability is a big question for most of them, and almost 90% of the patients, they spend out of pocket for their treatments. And if you look at the access to government setup in other states and in northeastern states, then our people, they go to the government hospitals more. Almost 89% of our people, they go to a government hospital. That is because of lack of money, because they cannot afford a private setup, so they have to go to a government setup. That's why we need good hospitals in the government setup. And number 5A is accountability, or rather lack of it. So many a times the central funds are available, but probably not properly used, or these are hard facts. I'm not going into the details or making it political, but if I have to enumerate why the non-communicable diseases are increasing in northeastern India, then these 5 A's: lack of awareness, lack of access, absence of human manpower, lack of affordability, and lack of accountability. Thank you.
Thank you so much, Dr. Vikas. You've, I think, very rightly highlighted some very important points, and especially you understand very well how they are pertinent in Northeast and especially in Assam. Now, I'd like to come to Dr. Mukut Roy. Dr. Roy, what is your take on NCDs, and what would you like to say about that? Non-communicable diseases. Because you're coming from such a specialized area, I would say, because in the east, and I think the terrain is different, and the food habits, the lifestyle is very different. Are they as prevalent in the other parts of country? Similarly, in Tripura as well, the place where you are providing your services.
Thank you, Dr. Rajesh Kesri, for inviting me to talk on this point. In fact, I also sincerely congratulate Associated Chamber of Commerce for bringing this topic as a factor of corporate social responsibility. So coming to the question, if you just see the nationwide scenario, you can see that NCD prevalent in the all over the country is the top 3 are the digestive diseases, diabetes, and hypertension, and followed by the respiratory borne diseases. Then after that, along with the cardiovascular disease and other disease factors. If you come to the northeastern part, specifically Assam, Manipur, Tripura, and this part of the country, then probably you can just think of that air pollution is probably not that important factor if you come to the northeastern state part of the country, and which is a very much important factor if you go to the metro cities and other part of the country, in the northern India, in the southern part of the India, or in the western part of the India. Having said that, again, if you go to the addiction habits of like tobacco consumption and the smoking, then again, these two, it becomes an important issue even in the rural population of the northeastern states, even in the different hilly areas. So again, if you think about the prevalent diseases, probably the airborne diseases and respiratory diseases are not that common in northeastern part of the country if you compare to the rest of India. But again, if you jump onto the cardiovascular disease, and if you jump onto the metabolic diseases like diabetes, and then features of the central obesity, then probably this comes almost equal in the urban part of the northeastern states if we compare with the other states of the country. So having said that, if you come to my state, then the different non-communicable diseases which are prevalent are the cardiovascular disease definitely, then followed by hypertension, then followed by diabetes. But again, if you compare the whole over the Northeast, then probably the hypertension is much more prevalent in the Assam, and then followed by Tripura, then followed by Manipur and other parts of the states. If you compare the pattern of diabetes, then it is almost comes nearer to the rest of the country. Like our country has got almost 11% of diabetes population, and in the Assam also it comes around 7.2%, and in Tripura it comes around 9.2%. Of course, 1% here and there. So again, if you go to the risk factors of diabetes and metabolic diseases and obesity, then probably the lack of physical activity, the nutritional status, then the early onset of obesity, that becomes one of the important key contributing factor. And then if you consider the role of NCD, if you consider the research by Mr. Kinshupato, I think he will highlight that in fact, Terry also has shown that we have got a huge number of young population, and 35 years of young population groups comprises approximately 65% of the Indian population. We have to mind that the NCD has got a quantum leap and quantum jump when it crosses more than 35 years. So any part of the country, I feel that the modification of lifestyle is important. Modification of addiction habits and avoidance of the addiction habit is very important, specifically in the northeastern part of the India. So that is my take. Thank you.
Thank you, Dr. That was very interesting because while sitting here in North India, we definitely wish to know how things are progressing, rather not progressing. What is the situation in the different parts of the country? And it is very important that more or less things are same. I'd like to go to Dr. Manas Barua. So what is your days? Yes, sir. So what would you like to say about non-communicable disease in your practice?
Yeah, so I will I look at it not from the point of view of Assam or Northeast right way. Let me talk about what we mean by non-communicable diseases. Non-communicable diseases are diseases of civilization and mechanization. That means to say that once a community becomes civilized and the health parameters improve, they start living longer. So it's a diseases of longevity. I mean, 1940s we used to have a lot of deaths from cholera, and then mortality rate was quite high, and then the life expectancy in India was about 40 years. Right now, the life expectancy in India is about 65 to 70 years, if I'm not wrong. Even in Kerala, it is even more than that. So now people are living longer, people are not dying of infectious diseases, which are communicable. Of course, of late, we have a communicable disease. It's a catastrophe. That's a different thing, COVID-19. Otherwise, we have been largely able to control communicable diseases. And then on the other side of the coin, you have these non-communicable diseases which are increasing. Then you look at the worldwide prevalence of non-communicable diseases. This is not only about civilization, it's about how rapidly you get civilized. You know, for example, look at diabetes and obesity. The highest rate of diabetes and obesity is in US, China, and India, and Indonesia, say. And within US, it is not the east coast or northern part of US which are suffering. It is a southern part and west coast where a lot of migrants are there, like migrants from African Americans and Mexicans, Hispanics and Indians and Chinese and many others who have migrated, and who have migrated from poorer countries to a very highly advanced civilization, and the lifestyles have changed suddenly. Within one generation, they become very, they plenty to eat, lot of, sophistication in their lifestyle, and they start living a sophisticated life, and they started having it. Say, for example, Eskimos would have prevalence of diabetes to the tune of 55 to 60%. That's because Eskimos, the leap was pretty steep from an uncivilized community to a very civilized community, looking at a US standard. And next one is the Arabs. Arabs also have got almost about 30% because they're also within 100 years, because of oil, they started becoming civilized and lifestyle change. Then, of course, we have the Indians and Chinese, where say about within a span of 60, 70 years, we have seen a lot of mechanization, cars and bikes and air-conditioned homes and all of facilities are there. So if you're rapidly progressing into a civilized state from a not uncivilized, underdeveloped state, then you're bound to have more non-communicable diseases like this. And talking about Northeast, Vikas and Mukut nicely pointed out a current problem, but I want to warn give you a cautionary statement here to my audience today, is that in Northeast, the prevalence is 7 to 9, say for diabetes, 7 to 9.5. Compared to the country, it is less. Compared to Kerala, it is much less. Compared to Punjab, it is much less. But this is the current situation. The worst is just yet to come, because recently from South India, Dr. A. Ramchandran has published a nice study where they have found that the highest rate of diabetes is not in the rural areas, not in the A-class cities, but in the townships. That means the cities, it may be stabilizing now, rural it is going up, but the small township where the lifestyle change is quite prominent. Small township now have the fast food, they now have the air condition, they now they're living in flats, they're now having 2-3 cars, and small townships have converted to townships only recently, last 20 years or so. So those families who have seen a significant rise in the standard of their livelihood in last 20-30 years, in those families, the next generations are going to suffer from diabetes. So that way, Northeast is full of townships. We don't have true cities here. Maybe 1 or 2 cities or 3 cities. But in true sense, we don't have the Tier A cities. These are all, township type, we are living like in townships. So in next 30 years or so, we are going to see a lot of people suffering from diabetes in next generation. So that is a warning. So it's high time we understand this. The Northeast, the percentage is low now, but it's going to go up. It's going to go up leaps and bounds.
Thank you so much, Dr. Manas. I think I'd like to add here that similar sort of transition is being seen, I think, in metros also, in Delhi and other places. There have been studies where people with good educational background and well-to-do people, the incidence of diabetes is going down, but in the economically backward section of the societies which are living in metros, in them the incidence of diabetes, dyslipidemia is very high. In fact, we were surprised to find the dyslipidemia, very high numbers of dyslipidemia in slum clusters which we studied. So the thing is actually happening in a similar way, that people who have migrated from small villages or very small towns to metros like Delhi, Mumbai, and maybe Guwahati also, they're getting a good life and they're having a very rich food, and at the same time they are not as physically active as they used to be in their little towns or villages. Maybe they used to work a lot, and as a result of that, as you all have pointed out, as a result of these lifestyle changes, we are having to deal with these non-communicable diseases. So I think we have done a very good context setting, and we have all contributed to the introduction of non-communicable disease in our respective specialties. I would here like to introduce to you all Mr. Kaushik Datta. Together with ASSOCHAM, he's heading an organization. He's heading an organization called Arbitrage. Together with ASSOCHAM, they have prepared a report on non-communicable diseases prevalence all over the country, all over India. They have studied 22 states, and they have surveyed more than 200,000 people. So it is quite representative of our country from very different states. So I would invite and I would request Sri Kaushik Datta ji to give us a short presentation about his report so that we can later on have some discussion on that report and other issues relating to non-communicable disease. So, Mr. Datta ji, would you please?
Sure. Thank you, Dr. Kesri. Will someone please give me the rights to share content? So, will the host please give me the rights to share content? Okay. Just give me a second because Chandar or Sandeep, will you please give me the rights to share content, please?
Paritosh, are you there?
Yes, sir. Mr. Paritosh is giving in a minute, sir.
Okay.
Will you? Yeah. Yeah. Thank you. Yeah. Yeah. So this is the report that we had done on non-communicable diseases for the entire country. The total sample of people who were interviewed for this report was roughly about 235,000. Out of that, roughly about 11,000 people were interviewed in the state, in Assam and in northeast of India. So that's a fairly large, sizable sample. I'm not a doctor. We are data analysts. So what we are going to give you is the insights that we got from interviewing 11,000 people in Northeast India on non-communicable diseases, and also the results of what's happening on the rest of the country. So if you look at this, this is your opening slide. There are 3 or 4 points out here. One is DALY. That DALY means disability adjusted life years. That means how many years do you actually live with the disease? Then obviously we had death. Then we have years of lives lost because of death and years of lives that you have lived with the disease. So if you look at this one, India, we roughly about years of life lost is about 50%, and which actually converts into 1,15 crores of years that we lose because of NCDs. And then years of life lost because of people who live with the disease. About 72% of the people actually live with the disease. And this, as you know, as the doctors have made it abundantly clear, is going to be one of the biggest killers in the recent future. And it has moved from 40% of total NCD-related deaths in 1990s to about 65% in 2019. That's a fairly large increase. Like all the doctors made this point, what happens is that if you have one of these NCDs, it goes and affects other NCDs, which is called other NCDs or other diseases, which is called comorbidities. And if you look at it, the comorbidity is actually the highest in the ones which are actually marked out in red. So if you have hypertension, the comorbidity is 22% with heart diseases, with cancer it's 6.4%, 24.3% with diabetes, respiratory diseases, and then with brain, kidney disorders, digestive diseases. And similarly, diabetes is the other one which has got a huge amount of comorbidities. So that means diabetes and hypertension not only just resides or stems in one disease, but it actually goes and affects significantly brings in other diseases and significantly affects other body parts. These are the key risk factors. These risk factors are based on international health matrices, which is approved by WHO. And if you look at this, the key risk factors that are there in India, it's fundamentally what you would expect, but these are not Northeast related. For instance, air pollution is one of the highest, low physical activity, your food habits, stress levels, the food you eat, in household consumption, household pollution, which is fundamentally women working in kitchens, so on and so forth. So how does the Northeast, the data that we picked up for Northeast, compare with the data that we have in India? We were actually very, very surprised to find that the incidence of NCDs in Northeast, and I've broken it down to between Assam and Northeast of India, is significantly higher than the national average. For instance, the national average of digestive diseases based on the 233,000 people that we saw, 3.19% of the population actually had digestive diseases. But in Assam, that was slightly larger and it's 4.23. And when we looked at the rest of the Northeast, it was significantly higher. Kidney disorders probably around the same. And the other place where it actually moves up very high is in the areas of hypertension. We did not expect to see respiratory diseases because of the points just made that the air pollution level is not lower. Air pollution and indoor air pollution and outdoor air pollution working conditions are lower in Northeast, but even the respiratory diseases are marginally higher than the rest of the country. So that's despite our initial assessment would be that it would be lower, but the data that we looked at and the survey results actually showed that it has got a higher than national average in relation to NCDs. So this is where it actually becomes very, very interesting. When Assam and the Northeast India, including Assam, the stress levels are actually much lower than the rest of the country. Any kind of stress relating to financial constraints, work pressure, it's actually significantly lower than India. So people by and large have got a reasonably stress-free life. Physical activities also, if you see, in most of the, physical activity at workplace, it's comparable than the rest of the country, but in medium labor is much higher, while highly intense labor, which is usually happens in construction sites and in very, very labor intensive factories, where India average is higher and Northeast is lower. But if you take a look at medium labor, which is basically working in the fields and others, the Northeast has got much higher physical activity than the rest of the country. And at home, that means like leisure activities, it's comparable to Indian average. So it's got enough physical activities which are the lack of which is associated with the NCDs. If you look at the quality of sleep, Northeast sleeps better than the rest of India. The BMI levels are at normal weight, it's there, but at the overweight or obese region, surprisingly, it is marginally higher than the Indian average. And also in the underweight section, it is marginally lower. That means there more proportion of underweight in the sample than for the rest of the country averages. Level of air pollution, as you expect, it's lower than the rest of the country. So respiratory diseases we would expect to see low, but as you have seen, the averages are a little higher. In relation to dietary habits, it's expected that the consumption of non-vegetarian food, which includes red meat and fish, and it's higher. And it's true with many other states. The red meat consumption is slightly higher than the rest of India, especially at the high category, which means more people who eat more frequently. That percentage is higher than national average, and that is not unexpected. Level of fruit and vegetables. So it's also actually quite comparable with the national average. It's marginally lower, but that is not something that would actually dramatically show up in the results when you correlate and you run statistical models. Same thing with legume and fish. It's got extremely high, I mean, it's not seafood, it's fish consumption. And also if you see the legume consumption is also quite high. So that means it's got strongly a balanced diet and a fairly healthy eating habits. But when it comes to carbonated drinks, it is, or the street food or processed food, that means like eating on the streets, that's quite comparable with the national average. And so from our dietary habits, there's no high risks that are coming out. But where do we actually think where the problem is? I mean, I would actually go back and I will show you data that reflects a lot of the things what Dr. Das has actually mentioned. 40% of the people actually in Northeast states only go and seek treatment when it's in a very critical stage compared to a national average of 17%. Hence, people are living for a much longer period with high morbidity. So if you, at the first stage, it's 56% who actually go in national, I mean, when you look at the national data, as against that in 39%. And as you go and see, the compulsion, and when it comes to a more advanced stage, people actually go and seek medical treatment. Why does that happen? Levels, because significant amount of the income, because of the access that was just mentioned, has to be private medical expenses that is paid. And if you have lower income, you try and defer your medical expenses as much as possible. And given the income disparity, this is one of the plausible reasons why the medical treatment seeking behavior takes somewhat of a backseat. And 87% of the people incur out-of-pocket expenditures compared to a national average. So it's close to 90%. And this is because, suggesting the penetration of government medical facilities are lower than the national average. And that's what also drives down into going back into a more close to a poverty situation, in which you spend, if you have a low income earner and you spend huge amount of money on your medical expenses, that actually puts you back into a poverty trap. And also the other point to be made is that government health scheme or government or group insurance policies is significantly lower than the national averages. Expenditure on NCDs is roughly at the lower level. You see that in roughly about 73% of the annual expenditure that happens, which is slightly higher than what is the national average. So people spend more on treatment, and there is less access. So it's a kind of, so the government access, which is free, is much lower. So that means people spend a lot more money out of their total income than it happens otherwise. So the points that I made, 40% of the people seek medical advance only at critical stage, as compared to 17% in Northeast, in 17% in India. Incidence level of alcohol and tobacco is higher than the national level. Red meat and non-vegetarian food consumption is lower, and lower income people have got much higher expenditure, putting them into a debt trap. And the greater out-of-pocket expenditure in the region in comparison to the national average suggests that we have much lower penetration of medical facilities. So thank you so much, and I'm sure that we will get medical views on the output that I have presented. And then if there is anything then from the data that you want us to explain, we'll be more than happy to do. So thank you, and over to you, Dr. Kesri.
Thank you so much. Thank you so much, Kaushik ji, for sharing these key points, especially keeping view the data from Assam and Northeast states. I think I'd like to start with on a positive note. One positive thing that I've noticed is that people in Assam in general, and maybe Northeast also, have less stress. I think that is something positive. They are maybe having a carefree life, but that carefree life, I think, is as Dr. Bikash had mentioned, maybe it's because of lack of awareness that they're having significantly high morbidities and they're landing up in hospitals, whether they're government or private. I don't think that we should make this segregation of government hospitals or private hospitals, because I've seen some of the best hospitals in our country are actually government hospitals. So it's not that all government hospitals uh, are same. I think access is more important than whether it is private or government. And we've seen that people in Assam are shelling out a lot more, 87% of out-of-pocket expenditure, whereas even earlier, about a decade back in our country, the national average was 80%. And it has been decreasing since then because of the number of government insurance policies and other measures. So, Dr. Bikash, I would like to come to you with this question that one thing I think you would be able to throw much light upon is that I was seeing that hypertension is a significant contributor to obviously morbidity and then mortality, because the cardiovascular deaths and arise from that. So, what is your take on that? What are the reasons, given that they have a good lifestyle, as I could understand from the survey? Is it true or not?
Yeah, I think it is absolutely true, and I should congratulate Dr. Kaushik Datta for giving us the insights, and we always kind of knew it that we have a bigger number of people suffering from hypertension and other problems, more than the national average. Because long way back, we did one ICMR actually did one study, and the national average of hypertension at present in India is around 33 to 35%. But in Assam or in northeastern people, it is around 65%, which is quite high. So ICMR did a pilot study, and it showed that especially among tea garden area population, and out of 3.4 crore of population of Assam, almost 20% of the population are tea garden population. And in them, that study was done, and they found that it is beyond 65%. The prevalence rate of hypertension is beyond 65%, which is almost double. So some of the reasons they found out that high consumption of salts, because salt was always, because we are far away from seas. So salt was always a very highly priced commodity in olden times. So people here use more, consume more salt. So they even put salt in tea. In morning tea, they instead of sugar, they put salt. And then they have a habit of taking this homemade liquor, which they call lau pani. And that homemade liquor, when they prepare it, they put lots of herbs into that. And that was found to be one of the causes of this high prevalence of hypertension. And there are so many other, we use or we consume lots of pickled products, and bamboo shoots and other things, and these dietary habits. So whenever we use used to make pickles, you use lots of salt, because salt is a preservative. So that way also we consume lots of salt. So that is one of the reasons of high prevalence of hypertension, and that's why the cardiovascular diseases are also very high, which Dr. Kaushik Datta has rightly found out that it is not low as we used to think. Like even for cardiovascular diseases in villages, the cause of death in India in urban areas is 25% for cardiovascular diseases. And even in villages, it is number one cause. The cardiovascular disease is still the number one cause of death among our population, and it is 18%. So the number of percentage is less, but still it is the number 1% region. So that way, I think the data is totally kind of what we always kind of thought of. And so I already have told you about the idiosyncrasies of the geographical terrain, the food habits, then the physical exercises and all. So all these things make a different kind of atmosphere here. So even the approach has to be Indianized. So what I really think is that we need Indian policy. What I mean by Indian policy is that uh, we have to have evidence-based data. That means like so the same policy which is say for New Delhi or Haryana or Gujarat may not be applicable for us because our patient population is different, our demography is different, and that's why our policy should also be different. So just like I made 5 A's for the reasons of increasing non-communicable diseases in Northeastern, I have enumerated 5 I's how to tackle it. Okay. I, so number one is increase expenditure. So we have to have more expenditure on healthcare. Like still the GDP expenditure of healthcare is still, I think, dismal. I just hope that it will increase after the COVID situations because nowadays even the politicians, they understand the value of an ICU bed or that we need to spend more on health. In Western countries, it is 18% of GDP, and here we are still struggling with 2.5%. So that increasing expenses should be there. So more budget should be allocated for healthcare infrastructure and other things. The number 2I is increase manpower. Already I have enumerated the lack of skilled manpower is a big problem, just like all over India. So in Northeastern also, like if you go to the tribal areas, like say Karbi Anglang district, particularly in Assam, or Dima Hasao district in Assam, these are hilly terrain. And the lack of infrastructure and lack of manpower is a big problem because the doctors and the nurses, they don't want to go to this very interior places and take up the treatment and all those things. I already have mentioned about Indian policy. That means evidence-based policy. So that policy is to be customized, particularly for Northeast and Assam. Then number 4I is IT. We have to implement and take help of the technology. So the telecommunication system has improved a lot all over India. And so we have to use the latest technologies like teleconferencing, video consultation and all. And it is picking up and it can play a big role, especially for interior areas where the doctors are not available. So even a patient can kind of directly contact with a skilled person and he can get some treatment and all. So this adoption of IT is number 4. And number 5 is inclusive growth. By inclusivity, I mean the incorporation of the private partners also. So the government has to take help of the private partners because there are some private players who are doing lots of good things. So maybe the government can partner with the private players and then extend the healthcare services even to the poorest of the poor. And we believe like in equity. So if you want to have that equity in healthcare also, then you have to partner with the private players so that you can give the best of the services to the poorest section also. So that is my take on your question. Thank you.
Thank you. I think you have very rightly underlined some very important points that the progress that we are seeing all over the country and all over the world, especially in the IT technology, in the telemedicine, telecommunications, and the public-private partnership, all these could be utilized in the local context, especially in context of Assam and Northeast, to improve the medical and healthcare services. Thank you so much. I think that was very wonderful thoughts. Dr. Gayatri, if you're there, I'd like to ask you, since we are having this very interesting discussion, and Dr. Bikash has just mentioned about the excess salt intake, and I was seeing in the presentation of Mr. Kaushik about the excessive non-vegetarian food intake that all we understand is a part and parcel of probably the normal northeastern diet. So do these two things somehow increase the renal diseases? What do you think and see as a nephrologist? And obviously the high salt intake which is causing hypertension. Excessive hypertension probably is a major cause of kidney failure or chronic kidney disease, and probably some other metabolic disease also.
Yeah, like Dr. Vikas has said about the intake of salt. The intake of salt is quite high in some of the communities of Assamese communities, especially the tea garden laborers, which he has mentioned correctly. Like it was study done in Dibrugarh where they had found that it was very high. So the salt intake in those communities are very high. But in the tribal communities, the other thing they take is that they used to take these dry things. They used to take this fish and this meat. They used to take the smoked forms. Okay, the most of them they used to preserve it with salt, or they used to sun dry it and they used to take it in a smoked form. So that can be one reason for increasing the incidence of renal diseases in these patients. As I had previously mentioned, that the main cause of kidney diseases in this population was found to be diabetes and hypertension. And since probably we are treating diabetes and hypertension well, these patients are surviving for a longer period, and now they are developing all those problems which we call the target organ damage. So the people of diabetes, which earlier used to stay for around 4 to 5 years, now they are surviving for almost 10 to 20 years. So now they are coming out with all the complications related with diabetes, long-standing diabetes, and then hypertension. The issue with hypertension is that many people are aware that they have got hypertension. They're taking medicine for it, but their main attitude is that they are taking medicine, but they are not, they don't know that whether their BP is getting controlled or not. So they are satisfied with the simple fact that they have got hypertension and they are taking medicine for it, but they are not concerned that whether that hypertension is getting controlled or not. And since hypertension is asymptomatic, most of the people won't have any symptoms of that, and it's called to be a silent killer. So the kidney failure because of hypertension, it will take time. It won't happen in one single day. So since the patient doesn't realize that he is having any problems, so he is not his adherence to medicine is probably not very good, and that's why he usually develops long-standing later on that leads to kidney failures. And like I said, that we have to see that salt intake is not only in the form of visible salt. Many of the time this salt intake is hidden, it's not visible. And like as there is a urbanization of our population, our community is getting more urban, like it's getting exposed to the new things like the junk food and all this carbonated drinks and all. So the intake of that fast food is increasing, and probably that is resulting in increase in the incidence of I would say, like, it is people have become more aware of the kidney diseases. Probably it was present there previously also, but it was probably not that apparent. But now people are concerned. People have come to realize the importance. Probably you have to take more of awareness measures to make them realize that because see, once the person has developed kidney disease and has gone into end stage, there's nothing much to do. As we see from data that only less than 10% of the patients who require permanent therapy, like renal replacement therapy, are receiving renal. Only 10% of those who requires are receiving it. 90% don't get it. So if we have to prevent kidney disease, we have to act early. We cannot prevent it at the last stage. So I guess, and there are other factors also. Some of few diseases which we have seen are more prevalent here in the northeastern regions, like IgA nephropathy and few glomerulonephritis. We are not sure what is the exact cause of this. We are still unaware of the causes. This may be environmental factor or this may be genetic factors. We have to do some studies, maybe more population-based studies to know more about these diseases.
Thank you, Dr. Gayatri. That was very insightful. Dr. Mukut, I would like to come to you, and I would like to have your opinion on. First of all, I think if there's so much salt, this high intake of salt, maybe you being an endocrinologist would enlighten us about the condition of other metabolic disease which may be related to salt or oncology. Is there any higher prevalence? Similarly, in like osteoporosis or GI cancers, has that been noted?
As you mentioned, of course, that is not on my part. But then, having said that, salt consumption is it is equally high in Tripura also, and in other parts of the northeastern state. And salt consumption, in a way, not only increases the blood pressure, but also probably a contributing factor for the other metabolic diseases. And also, in long run, probably may add to the cancer or other non-communicable diseases if the obesity is added to that. Having said that, if you think about the other non-communicable diseases along with the salt consumption, or the what about the other dietary points, what I wanted to say that what Dr. Kinshuk, Mr. Kinshuk Datta also highlighted in his view that if you compare the northeastern states from the other parts of the country, you can see that the physical activity is a bit higher in the office work or in the workplace. But if you compare the physical activity uh, in the workplace and the home, then in the home, I think the physical activity is almost similar to the other parts of the country. If you go to the real world practice, then probably you can see that one person goes to the office or for the work. The rest of the 3 or 4 family members stays in the family. And for the same reason, we can say that the rest of the person, those who are staying at home, they have got lack of physical activity. So in a simplified words. So that is not, you cannot separate from the other parts of the country. Again, having said that, the red meat consumption, if you consider the red meat consumption, the specific form of red meat, probably like mutton or other products which are consumed in other parts of the country, if you consider the northeastern state, then pork or beef consumption is somewhat a bit higher. Like I say that pork consumption is much more higher in the northeastern part of the state. Sometimes you start your breakfast with momo, and you finish your evening meal with fried foods like bora and other things which are having a high amount of trans fat and saturated fats. So there you can see the leap of change in the food. Even you can get a bora shop even in the remote villages these days. But then physical activity is not changing. Physical activity is still higher in the rural population. But the intake of the trans fat and saturated fats is becoming higher in the rural population along with the red meat consumption. Along with that, the addiction habits of tobacco and alcohol intake. The stress level, though it is a bit less probably, or somewhat marginally less from the rest of the country, but probably your lifestyle and the intake and choosing of the foods probably is not giving an added value for that point. So I will not isolate the higher level of salt consumption to the metabolic disease. Maybe it is an additional point for the hypertension and the cardiovascular disease. Of course, this is one of the contributing factors, but the other contributing factors like consumption of red meat, high consumption of red meat, then your high consumption of saturated fats and trans fat, along with that some amount of lack of physical activity, and also your addiction habit probably are the 2 important or 3 or 4 important key contributing factors. Along with that, of course, the legume consumption probably is marginal in the population.
Yes, I think, thank you so much, Dr. Mokad. I think you have underlined some very important points that together with excessive salt intake, which may be responsible for hypertension, there are other very important factors like the red meat consumption and the pork, and obviously the lifestyle, which has, despite the increase in the intake of saturated fats and others that you mentioned, the lifestyle hasn't changed.
Dr. Manush Pratim Barua also highlighted regarding the rapid urbanization, which
Yes.
was the important contributing factor. So that has happened in this part of the country also. So, and this is probably one of the key contributing factors. If you think about the thrifty gene hypothesis,
Yes,
we
yes.
all Indians suffer from the thrifty gene hypothesis.
Yes.
Basically, all we have got the lineage of the farmers and the hunter population, and now we have got a sudden sedentary lifestyle, and you have got on top of that now you have got the COVID and isolation and the lockdown period. So these are the things probably again will jump this important key contributing factor in the cities in the near future.
Thank you, Dr. I'd like to come to Dr. Manas Barua with a question. Actually, we are running out of time. We have already crossed our limit of time, but I would request each one of you to give a short message. So I'll come back after my question to Dr. Manas. I'll come back to each one of you, our esteemed panelists. Please prepare and give a short message to our viewers about the NCDs, about the prevention. What you would advise or suggest them to do and how to lead their lives so as to keep away from these diseases. Dr. Manas, I would like to come to you and I would like to ask a related question. One thing which I was thinking of was about obesity and diabetes, because we were seeing in the data that was presented by Mr. Kaushik that the obesity rates, if I'm not mistaken, are almost similar. So what is your take on obesity and diabetes and atherosclerosis? Because I think obesity is the root cause of multitude of the metabolic disorders that we are facing, and which ultimately lead to increased mortality.
You're asking in general, or
yes,
with respect to Northeast? Yeah, obesity. Yeah, obesity.
Since our focus today is on Northeast.
Obesity, we have to understand that obesity is, of course, related to various poorer outcome or various morbidities in terms of, mainly in terms of cardiovascular disease, also in terms of increased incidence of diabetes. But we must understand that there are two types of obesity. Actually, there is simple, the so-called cosmetic obesity. Your body weight is more than the cutoff BMI. But apart from that, there is something which we try to recognize, Dr. Mukut will agree with me, it's a metabolic obesity, where you may look lean, and which many Northeasterners are, but you have less muscle mass and more fat mass, especially in the abdomen. So your abdominal fat to the muscle ratio, the fat to lean mass ratio is pretty high. And that's what we are suffering from more actually in northeastern part of the country. BMI wise, we are not very high, but within that cutoff BMI of normal cutoff BMI, you have a lot of people who are metabolically obese and they are prone to develop more atherosclerosis and diabetes mellitus. So you must understand that we can counterbalance the ill effect of obesity by two things. One is that you burn down the extra fat, at the same time keep on building your muscle mass from a very early age, very early age, young age. So children have to be very active. If your children are not active, they're not going to build up enough muscle mass to counterbalance that, metabolic obesity. So you have to be active throughout the life, but you have to be active from the very beginning also. At least till the late adulthood and middle age period, you should be involved in rigorous exercises. But then unfortunately, what you see here is that 14, 15-year-old kids are now riding bikes, and they're not. There is no scope of cycling, and there is no physical activity, and so it's like a future is bit linked here unless we do something to prevent it. And of course, once you have the metabolic obesity, and once diabetes and hypertension comes in, then your lipid parameters which are wrong, kind of like LDL is high, and then low density lipoprotein in diabetes is of poor quality, which leads to more atherosclerotic events like heart attacks and stroke, etc. So to keep that that LDL in a better shape, not atherogenic, we must again, one, we have to do exercise, and another is we have to eat right kind of food, and you have to be physically active, and you don't have to build up your triglyceride, which is an immediate outcome of your fat intake. So there are various things in the diet which can help, and in your own diet, Northeastern diet, if it cooks properly, if it is taken properly, can help it. You don't have to go to the so-called Mediterranean diet, or you don't have to go for a fancy name. Actually, it's your own diet recipe which can be modified to suit your population. That's what is the most important. And finally, I would like to put my comment here, because I cannot come back because I have got some work left in my chamber. So my message to the Northeastern people is that we are endowed with nature's beauty, and everything is so natural here, and we should try to live near to the nature rather than moving out of it. So we have to strike the right balance with the natural resources which we have and build up our lifestyle based on natural resources, not on the so-called Westerner life. I mean, we need development, but we need development in the right direction, like healthcare, education, IT, etc. Not in the typical urbanized lifestyle that is not for Northeast, because that way, one, we are destroying our natural beauty, and two, we are naturally, we are disturbing our own life. So this is my simple message to the Northeasterners. And thank you very much, and thank you for giving me this opportunity.
Thank you so much, Dr. Manas Barua, for joining us, for being with us. Thank you so much. I'd like to come to Dr. Vikas, sir. Would you like to give a small message to our audience?
Yeah, I think my message is A, B, C, D, E. So A means assess risk. So whether you are at risk of developing a cardiovascular disease or not, you assess your risk with the help of a healthcare worker. Then B means blood pressure. Control the blood pressure below 130 by 80 millimeter of mercury. Then C means cholesterol. So if your cholesterol level is high, you have to take medicines or you have to do some exercises and bring it down. Then another C is for cigarettes or nicotine. So if you take cigarettes, because in northeastern population the smoking is very high, so you have to completely stop smoking, or even this chewable tobacco is also very high, so you have to stop those chewable tobaccos. So C means cholesterol and cigarettes. D means diet and weight. So diet, you have to take a healthy diet, as Dr. Manas has already mentioned, and you have to keep watching your weight. Then another D is diabetes. So if somebody is having diabetes, he has to control it with diet and exercise and with medications. Not only medications, but you have to bring it down. You have to control the diabetes. Only taking medicine won't help, but you have to control the diabetes, and that is what is the D stands for. Then number E is exercise. So if you can do some exercise, even if 4 days a week or 30 minutes a day, then it is very, very good. So kindly follow these instructions. It will help you prevent not only heart disease, but many other diseases, and you'll be able to live a healthy life. Thank you.
Thank you, Dr. Vikas. Thank you so much for this wonderful message. Dr. Gayatri, I would like to come to you and request you to give your message to our audience.
Okay, like Dr. Vikas and Dr. Manas has said, my advice would be also to you adopt a healthy lifestyle. We should have an access to healthy food, healthy water, clean water, and then we should do exercises regularly. We should take less of salt, less of sugar. Then we should not take tobacco. We have to limit our intake of alcohol. So those things you have to take. Then secondly is that since kidney disease in the initial stage remain mainly asymptomatic, so we have to screen for kidney disease. The screening for kidney disease should start very early. In diabetics and hypertension, if you got diabetes, if you got hypertension, you have to look out for kidney disease, because by the time they will present to you, it's too late. So you have to catch them early. There is a role of preventive medicine in these diseases. Secondly, you have to screen for high risk individuals. Like if you have a family history of like kidney disease, if you have family history of diabetes, you screen for those kidney diseases. Also, we have to avoid there is a saying, there is a thing in our population that if initial stages, people usually tend to go to these babas and they used to treat on their own. They will take some herbal medicine, they will take some any type of over the counter medicine. So that has to be stopped, because many of the times I've seen that taking of this over the counter medicine, NSAIDs, they lead to some chronic kidney diseases which could have been totally preventable. So use of those over the counter medicines we have to stop. And also we have to make it increase the awareness among the people, and it has to be started at a very even at the primary school level. We have to make the kids aware that intake of those fast food, the junk food, those carbonated drinks, they are not good, because after the age of 20, if you're going to stop them, it's not going to help. You have to start it at the very early stage. Nowadays we know that most of us are very busy. It's very difficult to cook home fresh food. So most of the time we try to this ready-made prepared food. but I think we have to go back to the nature and try to take those healthy foods. Also regarding policies and all, that has to be taken by the government. Government has taken a lot of steps. There are a lot of policies for treatment of kidney diseases, like we have got free dialysis facilities for patients, but I guess there is much more has to be done. So my advice is that prevention is the cure. So we have to prevent, to treat kidney disease, we have to start with prevention. So we need to control our diabetes, we have to control our hypertension, we have to see our food, we have to do exercises. That's all.
Thank you so much, Dr. Gayatri. You have very appropriately highlighted a very important point. Act early. Act early in all disease so that you don't reach a stage where the disease is untreatable. Dr. Mugut sir, your message to our audience.
Yeah. So thank you. The point is that this crystal clear from our three co-speakers, learning co-speakers. So my point is that first to go on avoid addiction, avoid tobacco and avoid alcohol. On diet, cut down your salt, cut down your red meat and cut down meat consumption. Continue the high intake of fish. On top of that, you add more amount of fresh fruit and green leafy vegetables and legumes if it is possible. And then for the disease onset, if you feel the symptoms are there, try to report to the doctors and the health attendants a bit early. Also, add to that, go for some amount of exercise. If not possible, at least 150 minutes of moderate work, 4 to 5 days a week. That should suffice the points. And on top of that, you are already, from the data, it has been shown that we have got less number of stress, we have got good amount of sleep. So I think if we have few of these points, and as if we target on these key NCDs, awareness that is important, as the way Associated Chamber of Commerce is doing today. It's a leading advantage on this awareness going to the real population. That is also important. Thank you.
Thank you so much. Thank you so much. I'm so grateful to all the esteemed panelists who have taken out their precious time and they've been with us for such a long time and guiding us and our audience about the important role of non-communicable disease and especially the factors which may be contributing to the increase and in the local context, in the context of Assam and Northeast states. Thank you so much. So a lot has been said. Obviously, I would not like to repeat, but I think the most important point that we can take out, a take-home message for all of us would be to have a healthy diet, to have a physically active lifestyle, to eat less salt, as we found out that may be a big problem. Basically, all the good things. And one point I would like to assert here is to increase physical activity in the children is very important. As Dr. Gayatri had said, act early. I would take that early to the very childhood. The more active our children are, the lesser they would develop all the other diseases like obesity, diabetes, hypertension, heart diseases. I think we've had wonderful input from all of you. There have been a lot of important points, and it would be difficult to repeat all those. Thank you so much, Dr. Mukund Roy. Thank you so much, Dr. Vikas. Thank you so much, Dr. Gayatri and Dr. Manas, for being with us. Hope to meet you again in a webinar or let's hope in a conference or seminar. Thank you so much. Jai Hind.